Today we're going to talk about some of the work we're doing on celiac disease and dermatitis herpetiformis in Nottingham. Mainly focusing on occurrence, I mean incidence and prevalence of disease and pregnancy outcome. But this work is, as Sarah alluded to, part of a wider series of projects that we've been funded to do in Nottingham by Celiac UK and Core, who gave us a grant about 18 months ago. I'm the principal investigator on that grant, and those are my co-investigators. Colin Crooks is here today, and he'll be speaking next, telling you about some of his work. We've also worked, actually, within this grant with some other collaborators. I'm very pleased to say that we've got Fabiana Zingoni here from Naples. She works with Carolina Ciacci, who you may know the name of from previous work in celiac disease. And we've also worked with Jonas Ludvigsson in Sweden. He's part of the team working on pregnancy outcomes, given his interest in doing work in that area. Just to explain, the studies you're going to see today are all based using routinely available data from general practice and hospitals. That's what we use. I've been using it for 14 years now in my research, and the people who are going to talk to you today are going to describe studies that have used those data. So to save them having to say what the data are, repeatedly, I'm going to just introduce it. Really, it's electronic data from general practices and hospitals that comes coded by the doctors and staff within those institutions. We have recording of prescriptions, diagnoses, procedures done, for pregnancy outcome, births, deliveries, mechanism of delivery, all sorts of data. And the data are linked together, and then we try and use them to study various diseases. Colin's work is based all in the general practice data set, called the CPRD. Fabiana's work is based in a data set called THIN, which is basically a sister data set of the CPRD, very, very similar, all based from general practice. And Alicia's work, who's going to speak last on pregnancy outcome, is making use of the linkage between hospital data and general practice data, which is a real step forward for us in terms of doing research, because you have outcomes and events from both sectors of the health service in the UK. The other thing they've used is a diagnosis algorithm for celiac disease, where they've used work that I originally did about over a decade ago now, sadly, it's so long, but really to show that when you study celiac disease using these data sets, you can believe the diagnosis of celiac disease. So, we have these conversations about whether or not people have got celiac disease, and I'm sure people will ask questions about it with respect to the work presented. But generally speaking, we use a diagnosis of celiac disease either recorded in primary care or sometimes secondary care, and we use a combination of gluten-free prescriptions. So we're pretty sure that the people you're being told about today have got celiac disease. So I'm going to get off the stage now and let three other people tell you about their work. They've got about 3 10-minute presentations. It's Colin first, then Fabiana, then Alicia. At the end I'll come back, tell you about some of the other projects we're doing, and I'll be more than happy to take questions at that time. So Colin first.
So good morning. Thank you for this opportunity to present our research. So we're going to be starting by looking at the incidence and occurrence of clinically diagnosed celiac disease and dermatitis herpetiformis across the UK. So why do we want to do this work? Well, we know from various other studies throughout the world that the seroprevalence of celiac disease seems remarkably consistent at about 1% in many different populations. However, when they look at the incidence of clinically diagnosed celiac disease, this seems to vary greatly from around 1 to over 40 per 100,000. And the highest figures come from areas in Scandinavia, such as Finland, where they have active case finding. And also where there's been longitudinal data, there appears to be an increase in the incidence of celiac disease over the last few decades. Particularly, there's been studies from the USA, from Finland, and more recently from Scotland that's going to be presented later on this afternoon. However, in contrast to all of this, dermatitis herpetiformis appears to be decreasing. This is only from one study in Finland, but if these two conditions are sharing the same pathology on an underlying basis, this seems to be a bit unusual. So we want to know what are the trends and patterns of clinically diagnosed celiac disease and dermatitis herpetiformis within the UK. So to do this, As Joe mentioned, we use the clinical practice research data links. That's all routinely collected anonymised data from primary care. This gives us 2 decades of clinical diagnoses and prescription. We then use this data to calculate incidence rates in the defined population that's registered to these practices. And we calculated this by age group, by sex, by year, and region of residence. And then we're able to calculate rate ratios adjusted for these factors using Poisson regression. So, what do we find? Well, first of all, our cohort had around 9,000 cases of incident celiac disease over the 2 decades. So that gives us an overall incidence of around 14 per 100,000. As you might expect, and has been published previously, there was a sex discrepancy in the incidence, with women having almost twice the incidence of men, and this persisted after adjusting for other factors. However, in contrast, dermatitis herpetiformis, we had around 800 cases, which gave us a 10-fold less incidence rate, around 1.2 per 100,000. And this time there isn't a difference between men and women in the incidence. They both have around the same. So what about the trends over time? So this graph shows the average 3-year incidence for lots of different age groups. Each line shows a different age group. And you can see that in almost every age group, the incidence of celiac disease is increasing. And the ones it's increasing the greatest in are those under 30 years old, and that's the bottom 2 lines, the yellow and the blue line. However, one age group didn't show an increase, and this was the under 5-year-olds, and that's the green bold line that I've just highlighted, and that stays around the mid-teens throughout the 2 decades. What about dermatitis herpetiformis? So this is the same type of graph, the incidence in different age groups. And you can see that in almost every age group, the opposite is happening. There's a decrease in the incidence over the last 2 decades. And this is statistically significant for all of the different age groups. What about differences in region? So these maps show the incidence on the left of celiac disease and on the right of dermatitis herpetiformis. The darker the colour, the higher the incidence. So on the left, you can see the incidence is ranging from around 10 to just over 20 per 100,000. And the lowest incidence appears to be around London, and the highest incidence, as you might expect, is in Northern Ireland. However, when we go on to look at dermatitis herpetiformis on the right, the pattern doesn't match. So these incidences now are ranging from just under 1 to just over 2 per 100,000, so they're 10-fold less. But the area of the highest incidence of dermatitis herpetiformis appears to be in the Hull and Humber region, which on the left had an average incidence of celiac disease. In contrast, when we look at the highest rate of celiac disease in Northern Ireland on the left, it has an average rate of dermatitis herpetiformis on the right. So a bit like the time trends, the patterns of incidence don't line up in the same way. So finally, we looked at prevalence of celiac disease. And as we mentioned previously, the seroprevalence of celiac disease is fairly consistent across the UK in different studies, whether it's Northern Ireland or mainland England. And it's all around between 1 and 1.6%. So we've calculated the prevalence in our study on the 30th of June 2011, and we found there's a range of prevalences from 0.16% in London up to 0.39% in Northern Ireland. So we had the same, as you might expect, over 2-fold difference in the prevalence. So overall, we calculated that within the UK there was a prevalence of celiac disease of 0.24%, which if we extrapolate to the whole population, that would give us around 150,000 people with celiac disease living in the UK. However, if we assume that prevalence is an underestimate, and actually the more appropriate prevalence would be that seen in Northern Ireland, seeing as they have the same seroprevalence, and that would mean there would be around 100,000 additional people with undiagnosed celiac disease within the UK. So in conclusion, we found an increasing incidence of celiac disease across the UK and in all age groups apart from the under 5s. We found similar incidence rates to that previously published for children in Scotland and also in Denmark. We found about half the incidence of that seen in areas of very high incidence such as Finland. We found differing regional patterns of diagnosis, and this could mean that there's higher ascertainment of disease in certain places, or that there's more clinical disease in certain places. We did do a number of sensitivity analysis and look at symptoms associated with diagnosis, gluten-free prescriptions and endoscopy, and these didn't change the patterns that we found. And in contrast to all this, we found there was a decreasing incidence of dermatitis herpetiformis, and this seemed to be occurring again in all age groups and across the country. And this would appear to provide more evidence to support a hypothesis put forward by the authors of the Finnish study, which suggests that maybe if we're diagnosing celiac disease earlier, we might be reducing the complication maybe of celiac disease or dermatitis herpetiformis. However, our research does seem to show that there are disparities in diagnostic pathways when we find such large variations in the incidence. So thank you very much for listening, and Fabiana is now going to come on and talk a bit more about socioeconomic differences.
Good morning, thank you for the opportunity to present our study. I am going to talk about the socioeconomic variation of childhood celiac disease in the UK. Although there has been an increase of celiac disease diagnosis, as Colin has just shown, diagnosed children still represent the tip of an hypothetical iceberg. From screening studies, we know that about 1% of children in the UK are positive for celiac disease serology. However, the actual number of diagnosed celiac disease children is still less than this value. This could be due to either the presence of undiagnosed asymptomatic children or the presence of undetected symptomatic children. Different factors could be implicated in this gap. For example, socioeconomic status may relate to the variation in celiac disease diagnosis. So we can imagine that the risk of celiac disease diagnosis varies according to socioeconomic status. There exists little literature on this particular topic on children. In particular, in the UK, have been published in the last years 3 different studies conducted in 3 different areas of the UK, bearing contradictory results. The Welsh study described, for example, a higher risk of celiac disease diagnosis in children from the least deprived areas compared to those from the most deprived areas. The Scottish one, instead, didn't find a large difference between the standard index of multiple deprivation and urban-rural indices in children with celiac disease and the general population. And finally, a study from Southeast England found completely opposite result, describing a higher risk of celiac disease diagnosis in children from manual social classes compared to those from professional social classes. So in view of these contradictory results and in view of the lack of a study including the overall children population in the UK, our aim was to evaluate the incidence of celiac disease in children belonging to different socioeconomic groups in the whole UK and in different countries of the UK. Our study population was composed of all children aged 0 to 18 who had registered with the Health Improvement Network General Practice, which is the dataset that we used for this research, at any time between 1993 and 2012. We measured the socioeconomic status according to the Townsend Index of Deprivation. We considered all children with celiac disease if they had at least one of these read codes in the GP dataset. We also took into account for different confounders such as age, sex, calendar year, and country of residence. The Townsend Index of Deprivation is a measure of area-level deprivation based on 4 indicators: local unemployment, car ownership, overcrowding, home ownership. It is divided in 5 quintiles, where the first quintile corresponded to the least deprived areas, and the fifth quintile corresponding to the most deprived area. So our study population was composed of more than 2 million children, followed for 3.8 years, corresponding to a total follow-up time of 10.5 person years, and we found during the study period from 1993 to 2012 1,247 celiac disease events, corresponding to an overall incidence of celiac disease of 11.8 per 100,000 person years. Looking at the different socioeconomic deprivation levels, we can see that we found the highest incidence rates of celiac disease in the first two quintiles, and then we can observe a progressive decrease of the celiac disease incidence in the last three quintiles, with the lowest incidence rate of celiac disease in children belonging to the most deprived areas. So, for example, we can say that the incidence of celiac disease is 80% higher in children belonging to the least deprived areas compared to children from the most deprived areas. So, we found a strong gradient across socioeconomic status in celiac disease diagnosis, such that children living in areas of high socioeconomic status were about twice as likely to be diagnosed as those living in areas of low socioeconomic status. And we found a similar relationship for both sexes, for all ages of children, and throughout all calendar periods. Now, looking at the different countries of the UK, we can observe a similar social gradient of celiac disease incidence in England and Scotland, where we found the highest incidence rates in the first two quintiles, and then we observed a progressive decrease of the incidence in the last three quintiles, similar to the incidence that we found in the whole of the UK. Even if this gradient is not very evident in Wales and Northern Ireland, probably due to the few number of cases that we found in these two countries of the UK, we always found the lower incidence rates in the more deprived areas. Our studies some strengths. The main strengths are that it is the largest study conducted so far on this particular topic. We adjusted our result for potential confounders such as age, sex, calendar years. We used a validated method for celiac disease diagnosis, and our findings can be considered representative for the whole children population in the UK. However, there are also some limitations. For example, the Townsend Index of Deprivation gives the overall deprivation index of people living in a particular area. So we don't know individual deprivation level, and this score doesn't. We don't know also the probably difference between urban and rural areas. Moreover, there are some missing values concerning socioeconomic deprivation level that could compromise our results. And finally, as said before, we found few celiac disease events in Wales and Northern Ireland, probably due to the fewer number of GPs that collect information for team in these areas. And this fact could compromise our statistical power. In conclusion, we cannot say if there is a real reduced risk of celiac disease among children from the most deprived areas, or if there is just a low detection of celiac disease in these areas of the UK. For example, we can imagine that different behavior towards medical consultation among people from different social groups, meaning that, for example, parents from the most deprived areas may be less likely to seek medical consultation, or, for example, that parents from the least deprived areas ask for consultation more often compared to parents from the most deprived areas, also for in case of mild symptoms of their children. So in view of this, mechanisms to improve diagnostic pathways in socially deprived areas could lead to better outcomes for those people who have not been diagnosed yet. However, we cannot exclude the possibility that people of different socioeconomic status are exposed to different risk factors, which might indirectly contribute to celiac disease development. So in view of this, future studies should explore the possible association between exposure to different specific risk factors and the risk of celiac disease among children belonging to the most deprived areas. Thank you. Now, Ali.
Thank you for the opportunity to speak, and thank you, Joe, for the introduction. So today I'll be talking about pregnancy complications and adverse birth outcome among those with celiac disease, which is a population-based cohort study from England. So as Fabiana and Colin already mentioned, that subclinical evidence of celiac disease is present in around 1% of the most European population, of which approximately 0.2% have been clinically diagnosed. This suggests that about 10 in 1,000 pregnant women could have some form of latent or undetected celiac disease, and about 2 in 1,000 pregnant women may have known celiac disease. Given the estimated prevalence of celiac disease and the adverse physiological effect it might have, it is surprising that so few studies have looked into the risk of adverse pregnancy outcome among those with this disease. Previous studies that have been done on the topic can be broadly categorized as either case series of individual or multiple centers pooled together, or registry-based studies. Now, case series studies, what they do is they take a couple of pregnant women attending a particular hospital, and they screen them for positive serology for celiac disease. They look at the outcome among those with positive serology and compare them to those with negative serology. And this gives them really small number of events, less than 150 cases, which gives estimates which are inconsistent. For instance, a study by Martinelli reported that the 12 pregnant women they found to have undiagnosed celiac disease were more likely to have babies with low birth weight compared to those with negative serology. However, a similar study based on 52 cases from multiple centers found that there was no excess risk of low birth in offsprings. Then there are registry-based studies from Sweden and Denmark, and they use large registry databases. However, they use hospital admissions to identify celiac cases, and in most cases they might not include cases recorded or diagnosed outside hospital. This leads to the underestimation. This leads to the underestimation of the prevalence of celiac disease. And they may also introduce some form of selection bias as they use hospital admission. So they may include severe form of celiac disease, who are more likely, patients who are more likely to be admitted in hospital, and therefore they are more likely to get adverse birth outcomes. So the accurate estimates of risk of adverse birth outcomes and pregnancy complications that are generalizable to majority of the pregnant women will aid both a clinical practitioner and women in better decision making. Therefore, we carried out a population-based cohort study using primary and secondary care data from England to quantify the risk of pregnancy complication and adverse birth outcome among women with celiac disease. For this purpose, we utilized the clinical practice research data link, as Joe already talked about. For this particular piece of work, we utilized a study which was, we utilized a portion of CPRD which was linked to the hospital episode statistics data. So at the time of the study analysis, the version which I used included more than 300 practices across England and which had information on more than 6 million patients. So our study population included women aged 15 to 44-year-old with HES recorded singleton pregnancy ending in a live or a stillbirth between 1997 and 2012. Our exposure was defined as celiac diagnosis recorded in journal practice record. As Joe already mentioned, this celiac disease diagnosis has already been validated in these data. Pregnant women were grouped together as having diagnosed before childbirth. We call that group as having diagnosed celiac, or if it was diagnosed after childbirth, we call that group undiagnosed, those with undiagnosed celiac. Then we looked at the outcomes, which were pregnancy or delivery-related complications. We looked at the mode of delivery. We also looked at antepartum and postpartum hemorrhage, and also preeclampsia or eclampsia. We also looked at adverse birth outcomes, which included stillbirth, preterm birth, and babies born with low birth weight. For our analysis, we calculated proportion of all pregnancy and birth outcomes among women with and without celiac disease. We ran a logistic regression model to assess the association between both diagnosed and undiagnosed celiac disease and pregnancy outcome in terms of odds ratio. We also fitted a clustering term to account for more than one pregnancy experienced by a woman in our model. So what did we find? Our study population included more than 270,000 women in our, who experienced more than 366,000 singleton pregnancies resulting in live or stillbirth. We had around a total of 892 pregnancies were complicated with celiac disease, which gave us the prevalence of 0.25%. 62% were categorized as having diagnosed celiac disease, whereas 38% were categorized as having undiagnosed celiac disease. We also had more than 363,000 pregnant women which did not have celiac disease. This served as our comparison group. Some basic demographics. Compared to women without celiac disease, women with celiac disease had lower BMI, were less likely to smoke, had high prevalence of diabetes, and pregnant women with diagnosed celiac were older than the undiagnosed, those with undiagnosed, but otherwise had more or less similar maternal characteristics. So this table shows the absolute and relative risk of pregnancy complication and adverse birth outcomes among women with and without celiac disease. Here we have the outcomes that we measured, and this column shows the number of pregnancies which did not have celiac disease, and here we have the those percentages, proportions, and over here we have women who had celiac disease, the number of pregnancies and the proportions. So if we look at the postpartum hemorrhage, compared to those who did not have celiac disease, the absolute excess risk was only observed to be 1.7%. So here it's 9.7 in the non-celiac and 11.4 in the those with celiac disease. And then for eclampsia and preeclampsia, the proportion was were more or less similar. In terms of mode of delivery, those with celiac disease had 2% excess risk of assisted delivery compared to those without celiac disease. But here you can see that none of the associations are statistically significant with all the pregnancy complications. And here you can see that the birth outcome that we looked at, which was stillbirth, preterm birth, and babies born with low birth weight, the risk difference is really small compared to the control, compared to those without celiac disease. And once again, none of these are statistically significant. This shows the relative risk of pregnancy complication and adverse birth outcomes among those with diagnosed celiac disease and compared to those without celiac disease. So these are the absolute excess risk compared to the control population. And here you can see that those with celiac disease, those with diagnosed celiac disease had 3.5% increased risk compared to those without celiac disease. But these, for all these outcomes, the excess risk is really small. Then we move on to the relative risk of pregnancy complication and adverse birth outcome among women with undiagnosed celiac disease. And once again, you can see that the absolute excess risk for those with undiagnosed celiac disease compared to those without celiac disease are really small for most of these outcomes. And none of these associations are statistically significant. In terms of the strength and limitation, the biggest strength of this study is that we used a large data set from both primary and secondary care sources. We looked at we ascertained our exposure to celiac disease from primary care data, and we also looked at our outcomes in the secondary care data. And as these data sets are routinely collected, there is minimum selection bias. These estimates, as the population in our linked data, are representative of the general population. This provides the generalizable and contemporary estimates. And lastly, our CD definition has been validated in the primary care data. The limitation is that we did not have compliance data. Those who were categorized as having diagnosed celiac disease were automatically assumed to have been compliant to the gluten-free diet, which may not always be true. However, complete non-compliance is not so common in those with celiac disease. There could be some misclassification between diagnosed and undiagnosed celiac disease. As we already mentioned, that the seroprevalence is 1%, however 0.2% of them are clinically diagnosed. Therefore, this could move our estimates towards null. However, there are other studies which supports our finding, and they also found that those with undiagnosed celiac disease have no increased risk of having low birth babies. Secondly, power. For some of our outcomes, we did not have sufficient power. There were a few cases, particularly in the case of stillbirth. So there may be, we may miss out some of the small risk increases. Nonetheless, we did present the absolute risk associated with those outcomes, which we think is of clinical importance. So in the conclusion, most women with celiac disease, either before or after pregnancy, will have a delivery or pregnancy that is not complicated by an adverse event. Among women already diagnosed with celiac disease, there may be a small increased risk of pregnancy being complicated by postpartum hemorrhage, but the reasons for this association is not entirely clear. Finally, overall, our results should be assuring to both women and clinical practitioner. Thank you.
Okay, and that is it. In summary, Colin, Fabiana and Alicia have told you about their work on occurrence and variation of socioeconomic status of the incidence of celiac disease and the adverse pregnancy outcomes. We've done a lot of other studies as part of the grant that we're doing, and a lot of other people doing them, but hopefully we'll come and tell you about that another time. I'm happy to take questions, and Dave's going to, take charge.
Thank you very much. Any questions from the floor? Can I ask you guys to come up as well, just in case anybody wants to ask a specific question? May I make one point before that, which is that the results and things that were presented by the Nottingham group are still under review. So from a press perspective, there's an embargo for that. And if there are other presenters who have that, could they mention it at the beginning of their talks? I'd be very grateful. Questions? Professor Joe.
We know that the incidence of atopic diseases as well as inflammatory bowel disease is increased in children who grow up in very clean environments, and that roughly correlates with social class. So do you think the hygiene hypothesis is relevant for celiac disease?
Yeah, could be. Because the hygiene hypothesis does say that a lower exposure to infection during childhood could increase the risk of immune disease, such as celiac disease. So in our cases, the higher risk of infection during childhood in children from the most deprived areas could protect them from the development of celiac disease. This is in contrast with the previous evidence that some infection could increase the risk of celiac disease, really. But yes, could be a good reason. For us, the main reason could be the low detection, but it's possible that there is a contribution for these two factors.
You don't have data on antibiotic usage?
We have, but we have not analyzed it yet.
That's next, I think.
It's next. It's the next. Next step.
Any further questions?
Can I just ask you about the falling incidence of dermatitis herpetiformis? Because one of the suggestions from the Finnish group was that the diet is changing in Finland and the intake of bread has fallen by 50%. By definition, you wouldn't go to a celiac clinic if you had dermatitis herpetiformis, if you were predetermined to get it, because it's so mild. By definition, you don't go to it, you present in a skin clinic. So the argument about treating celiacs early prevents dermatitis herpetiformis is only probably half the story.
Yeah, I agree. That's only a hypothesis they put forward in one of their papers. We were just saying it was consistent with that. In terms of dermatitis herpetiformis going to dermatology clinics rather than celiac clinics, we would still have picked up the diagnosis because one would look at primary care, and both those clinics would communicate the diagnosis back to primary care. And also, we've done sensitivity analysis looking at those within a prescription for dapsone, and the pattern remains the same for if you restrict it to that population.
Time for one final question, I think.
My question's also for Fabiana. Fabiana, you showed that there was a lower prevalence in lower socioeconomic groups. Given there's a difference in enrichment of genes for celiac disease in different ethnic groups, did you adjust for ethnicity in your analysis?
No, we don't adjust for this. Also because we know that about 90% of the ethnicity in the UK is white. So it's difficult that this could influence our results.
But it's often explained that the low prevalence of celiac disease in London is because of the ethnic diversity of London. So and we know that ethnic group migrant populations are more likely to be the lower socioeconomic groups. So could it actually be that you're just measuring a lower prevalence in ethnicity?
Yeah, we don't look at the single region in the UK, but we have the data, so we can do that in the future.
Okay, thank you. Jeremy, I'd love to give you a question, but I want to run to time, perhaps at the break.
Are there any hints or clues from the epidemiological data that can help us to unpick the difference in ascertainment from the true incidence, in sense of how much of this incidence is actually just ascertainment in effects and in both the paediatric and the adult data, and how much is it's actually true increase in incidence? There may be some clues that you can use from the epidemiological data you've got to try and get some hints at which of those it is.
I mean, that's a very difficult question to answer, really, and I'd love to be able to. I mean, there's some hints from the Scottish data that they didn't see a change in the severity of disease diagnosed among children, and still saw an increased risk in increasing incidence over time, which might suggest, therefore, that the so sick children, the number of sick children occurring in the general population was actually occurring more commonly over time, and so that would suggest perhaps that it wasn't all ascertainment. But it's very difficult to get around the fact that in 1992, EMA arrived, and in 1987 glidin arrived, and then in 1997 TTG arrived, and there's been a huge investment in endoscopy. So to tease out the two aspects of the NHS care and real incidence, I think will take time. If you look in America, Jonas's paper from Olmsted County, he looked over about 15 years, and in 2006 to 2010, actually the incidence flattened off. Okay, so it became flat, which suspects that they'd essentially captured everybody, and then they sort of got to the threshold. But that's another 20 years of my career to sort of